So we'll discuss now what are the drugs which are used in cough. So before discussing the drugs, first we will understand little about what is cough. Cough is basically a very protective mechanism which are designed by our body. So it is a protective mechanism. What happens? Why this cough is important? So it is protective for our body. Whenever we inhale the foreign particles, like anything we inhale which is not required by our body. So suppose we inhale the foreign particles, it will goes inside our lung. It tries to goes inside our lung through our throat, and then it goes to our respiratory passages, and from the respiratory passage it goes to the lungs. So if it is not required by our body, there are certain receptors which on seeing these foreign particles they get activated. These are present in our throat and in our respiratory passage. These are the chemoreceptors, or they are also called mechanoreceptors. And some of the receptors are also present on the lung, that are the stretch receptors. So if these foreign particles goes inside through the respiratory passages, these mechanoreceptors, if they are not required, they start getting stimulated. The stretch receptors and mechanoreceptors, or the chemoreceptors, they give the signal, very powerful signal, to throw these foreign particles out of the body. So it is important because we don't require these foreign particles. These are not required for our lungs, which are not good for our lungs. So this is important mechanism. That's why the things which are not required by our lungs, they are thrown out. So this way the protective mechanism, this way cough helps in removing the foreign particles which are not required by the body by the stimulation of receptors like the chemoreceptors and the stretch receptors. Chemoreceptors are located on our throat and respiratory passages, while the stretch receptors are present inside the lung. Now also what we have to understand here, what type of cough we are going to suppress. If it is dry cough is useless cough, it is not required. It is unnecessarily creating trouble for the patient. Patient keep on coughing and start having a lot of musculoskeletal pain and other symptoms. So dry cough is non-specific, it needs to be suppressed with the use of drugs. But if the cough is wet, that means it contains some secretions, and if the secretions are there, it will remain in the lungs. If we suppress these secretions, then what happens, that it will collect in the lungs and that will create infection. So wet cough does not need to be suppressed. We have the patient, if can throw this cough out, it is good. We don't need to suppress it. We have to find the underlying cause of the wet cough and then we will treat it. But for the dry cough, we can suppress it. So let's study the classification of drugs used for cough. We have the demulcents, we have the expectorants and antitussives and adjuvant antitussives. So these are the groups of drugs which are available. So first talk about the demulcents. So what these demulcents do? Whatever, first we should know, whenever there occurs the cough, because of excessive coughing, there occurs the inflammation in the throat and in the respiratory passages. There is a lot of inflammation, and these inflammatory signals, the irritated throat and irritated respiratory passages, they send the signal to our brain, and because of which the patient experiences pain in the throat and in the respiratory passages. These are the afferent impulses which are carried to the brain by the excessive coughing. Afferent impulses. So what happens when we give demulcents to the patients, these afferent impulses is being blocked from the throat and the respiratory passage, and the patient will having very soothing of the throat and the pain signal gets stopped. This is how the demulcents acts. They basically block the afferent impulses that is going to the brain from the throat and the respiratory passages, and the irritated throat and irritated respiratory passages, they become less of the inflammation goes very down, and the patient gets relieved of pain in the throat and other symptomatic relief. They are basically providing symptomatic relief to the patient. Now about the expectorants. How does these expectorants? These expectorants are also called mucokinetics. So what happens when patient is having cough? They are basically having some secretions which are being stick to the respiratory passages. There are certain secretions which are being stick to the respiratory passage, and these patients have constant desire of coughing again and again. So what these expectorant group of drugs do, they basically break down these mucus secretions. They break down these secretions. They break down these secretions, and also they enhance the bronchial secretion from the bronchial. There are a lot of glands present in the bronchial tree, and they try to increase the secretions in the bronchial tree. They increase the lot of secretions, and they break down these mucus plugs. And because there are a lot of secretion and there is breakdown of the mucus, and when patient tries to cough, these material which are being collected in these respiratory passage, they easily pass out through respiratory passages out of the body. So in this way, the expectorants helps in clearing the airway. Now about the antitussive group of drugs, they basically act at the central nervous system. So normally what happens, these are our lungs, these are the brain. So what happens, this brain sends the signal to our respiratory tract for initiating the cough whenever we inhale the foreign material. Also in the lung also gets stimulated by foreign material. There are peripheral action also. So these antitussive groups of drugs block these signals from the brain to the respiratory tract, and because of which the respiratory tract is unable to initiate the cough. So antitussive cough act at the central nervous system level mostly, and also at the peripheral level. They basically block the signal from the brain to the lung to initiate the cough. So because of which cough is not initiated, and the patient gets relieved of cough. They are basically used for dry cough. It is not good for initiating and giving the antitussives for wet cough. About the adjuvant group of drugs. So what happens during coughing? This is bronchus which takes the air into our lungs. So in some cases of cough, there occurs the bronchospasm. There occur the bronchospasm or bronchoconstrictions. So this adjuvant group of drugs, they dilate these bronchus. They cause the bronchodilation. Because of bronchodilation, there is easy movement of the secretion out of the body, and the patient gets relieved of coughing. So they also provide a symptomatic relief mostly. They are to be used only when the component of bronchoconstriction is present. First talk about the pharyngeal demulcents. So as we already discussed, they basically block the afferent signals. So what happens whenever we cough? There are the signals which are coming from the throat and the respiratory passages. There are the signals which are coming from the throat and our respiratory passages. These signals are very painful and causes pain in the throat and the respiratory passages. There is a lot of pain, and these afferent signals are being blocked by these demulcents group of drug. They block these afferent signals, which is going to the brain. They basically soothe our throat and provide the symptomatic relief. The drugs in this group, we have the lozenges, we have the cough drops, we have the linctusis, glycerin, and licorice. So these are the group of drugs which are called the pharyngeal demulcents, and they provide a symptomatic relief to the patient.
Talk about the expectorant group of drug. These are also called as mucokinetics. They are also called as mucokinetics. So what these expectorants group of drug do? First, we understand what happens in patient who is having a lot of cough. There are a lot of secretions which are being collected in their respiratory passages, and they are unable to remove the secretion out of their respiratory tract, and because of which they have constant desire to cough. They have sticky throat. So what happens? What these drugs group do? They will try to break down these secretions. They try to break down these secretions. The drugs in this group which try to break down these mucus secretions, they are called as the mucolytics, and also they also induces the fluid material in these secretions because of induction of the fluidity in the material here in this respiratory passage, and also because of the breakdown of this mucus, because of which there is a lot of liquidity formed in this area, and this helps in easy clearing this material from the respiratory tract, and the patient gets relieved of cough. And the drug which increase the bronchial secretion, because there are glands which are present in the respiratory tract, they enhances the secretion from this gland. They are called bronchial secretion enhancer. In this group we have the sodium and potassium citrate, potassium iodide, and guanfacine. And in the mucolytics which try to break down these mucus here, these groups include promexine, ambroxol, acetylcysteine, and carbocysteine. So because mucolytics try to break down the secretions, and bronchial secretion enhancers increases the fluidity content in the respiratory tract, this will help in easy removal of the secretion from their respiratory tract. So in this way, mucokinetics are the expectorants act.
So we continue our topic. We are discussing the drugs which are used for cough. We are discussing expectorants. In the expectorants, there are two group of drugs. We have the drugs which increase the bronchial secretion, and there are drugs which break down the mucus. The drugs which break down the mucus, they are called as mucolytics. In this group, we have the bromexine, ambroxol, acetylcysteine, and carbocysteine. Today, we will be talking about bromexine group of mucolytics. So this bromexine is a mucolytic. This break down the mucus in our respiratory passages. What it does, in the sputum we have a lot of mucopolysaccharides. Mucopolysaccharidase is present in the sputum, and that mucopolysaccharide is in the polymerized form, and this mucopolysaccharide keep the sputum thick, viscous, and that thick viscous sputum is very sticky to our respiratory passages. So when we give bromexine to the patient, it directly depolymerizes this mucopolysaccharide. It depolymerizes this mucopolysaccharide, and thus makes this thick sputum into thin, and this less viscous sputum is easily passed out of the respiratory tract. So when we give this syrup bromexine, it will convert this mucopolysaccharide in the which was polymerized form into depolymerized form. Also, it also causes release of certain lysosomal enzyme on the mucopolysaccharide and break down this mucopolysaccharide into thin strands, and that is easily make the sputum very thin, and it is passed out of the respiratory tract. So here we can see in adults we use 8 mg of tablet of bromexine, or we can also use the syrup. This is a 100 ml bromexine syrup, bromexine hydrochloride. Here it is written, it helps in clearing our chest congestion. So each 5 ml of the syrup contain 4 mg of bromexine. For a child in the age group of 1 to 5 year, we give 4 mg BD. That means 5 ml BD dose. For 5 to 10 year of age, we give 4 mg TDS 3 times a day. Since it breaks down the mucus and converts the mucus into thin mucus, thick mucus is converted to thin form with the use of this bromexine. It also thinned out secretion in various other parts of the body, and thus producing various side effects. Like it in the eyes, it thins the secretions, and that can cause lot of lacrimation. In the nose, it can cause rhinorrhea. In the gastrointestinal tract, since there is a mucus layer which prevents this acidic damage to the stomach because of the presence of mucus layer. But when we give this bromazine syrup, it breaks down this mucus layer and thus predispose the patient to ulceration, that is, it can cause peptic ulcer disease, since it breaks down the mucus, which is protective for the stomach. Since mucus is broken down, and they are more predisposed to ulceration. It can also cause hypersensitivity reactions. So this was about bromazine. One more mucolytic drug is the ambroxol. This is also a mucolytic. It also converts the thick viscous sputum into thin sputum, and it is easily removed from our respiratory passages when the sputum becomes thinned. And its action is almost similar to bromexine, that it breaks down the mucopolysaccharide present in the sputum. So its action is almost similar to bromexine, and also the side effects are similar to bromexine, that it can cause lacrimation and rhinorrhea and ulcerations in the abdomen. So this ambroxol comes in form of tablet and in the form of syrup. The tablet comes as, for the adult, the dose is 30 mg, which is given thrice daily dose of ambroxol. In the syrup, its 5 ml contain 30 mg of ambroxol. For children, if the children age is more than 10 years, it is given 5 ml thrice daily. Between 5 to 10 years, 5 ml twice a day it is given, and between 2 to 5 years, it is given 2.5 ml thrice a day. For less than 2 years, it is given 2.5 ml twice a day.
So this is the ambroxol syrup which is used in children. It is 100 ml and 505 ml contains 30 mg of ambroxol. Another drug is acetylcysteine. It is also a mucolytic. So what does it act? How does it act? It basically converts this thick mucus into thin mucus. It goes into the sputum, and in the sputum there are present mucoproteins. These are the mucoproteins which are present, and each mucoproteins bounded with each other with the help of these bonds. These bonds are called as the disulfide bonds. And because of the presence of disulfide bonds, these mucoproteins remain attached to each other in the sputum. They are attached with each other with the help of disulfide bond, and this makes the sputum very thick, and because of which it is very difficult to remove the sputum from the respiratory passage. So when we give this acetylcysteine to the patient, what does it do? It goes into the sputum and breaks down these disulfide bonds present in the sputum, and because of which these mucoproteins are broken down, and the sputum, which is very thick, it becomes very thin because of the breakdown of mucoproteins, because of the breakdown of disulfide bonds present in the mucoproteins. So this acetylcysteine is used in those conditions where the mucus is very thick and it is very difficult to remove the mucus from the body. For example, in those patients who are tracheostomized, and in the tracheostomy tube, there are a lot of secretions which are collected. So this thick sputum is what we do. We will give these injection, or it is directly injected into the tracheostomy tube, these ampules containing the acetylcysteine. So this 2 ml contains 400 mg of acetylcysteine. It is directly nebulized, or it is directly inserted into the tracheostomy tube, and this tracheostomy tube containing the thick sputum, it becomes very thin, and it is easily removed from the tracheostomy tube by suctioning. It can also be nebulized in those patients who are having sticky chest and chest congestion, where there is a lot of sputum has been collected, because the sputum becomes thick and it is difficult to remove. For that, we also give these acetylcysteine nebulization, or we can directly insert these ampules in tracheostomy tube for removing the thick sputum. And this acetylcysteine, since it is also breaking the mucus, it can cause peptic ulcer disease. Another drug is carbocysteine. It is also a mucolytic, and its action is also similar to acetylcysteine. So this carbocysteine comes in the form of capsule, which is 375 mg of capsule of carbocysteine, or it can come in the form of syrup, where 5 ml of carbocysteine contains 250 mg. 5 ml of the syrup contains 250 mg of carbocysteine. So we can combine this carbocysteine with antibiotics like amoxicillin or cephalexin. When this carbocysteine combined with amoxicillin, it is called carbomex, and when it is combined with cephalexin, it is called as carbicef. Here the dose of carbocysteine is 150 mg, while the dose of antibiotic is 250 and 500 mg. So this antibiotic is required in conditions where there is component of infection present. For example, in patients with chronic bronchitis, where the mucus is thick and there is likely risk of infection in the mucus. So we give them in chronic bronchitis. We also give them in bronchiectasis, where is also infection component is there, and in sinusitis. So its action is almost similar to acetylcysteine, and also it can cause it is contraindicated in peptic ulcer disease, as it breaks down these mucus layers, because it is mucolytic and it breaks down the mucus layer, and this stomach be predisposed to acid damage, and that's why it is contraindicated in patient with peptic ulcer disease. So these was the group of drugs. These are the mucolytics we used in cough. Reasons why the cough occurs. So any patient who comes to us with the cough, we are only give the cough suppressants and send the patient home. But sometimes this can be harmful to the patient, so we have to treat the underlying cause. What is the exact reason why this cough is occurring, and we have to find this cause and then we treat. So we have to properly, thoroughly take the history and examination, and then we when underlying cause will be find, and then we will treat that underlying cause, and then the cough will go away. For example, if the patient comes with some symptoms of headache, running nose, and like sometimes some patient may have dry cough and sinusitis. So these are the symptoms of upper respiratory tract infections. And also some patients can have cough. Along with cough, there is a lot of sputum, and sometimes patient can have fever, chills, and cough with sputum production, and these are the symptoms of lower respiratory tract infections. And if the infections component is adding to the cough, then what is we are going to do then? As we know, if infection is occurring, then we have to give the antibiotics to such patients. So here the antibiotics will help. So these types of cough require antibiotics. Then sometimes the patient are quite chronic smoker, and they keep on smoking, and this smoking and sometimes the patients are exposed to a lot of pollution, and this pollution and these smoking particles are very much irritated for our respiratory passages, and in the respiratory passages they cause the inflammation in our respiratory tract, and this inflammation in the respiratory tract leads to chronic bronchitis. Also chronic bronchitis. So these patients who are exposed to smoking, pollutants, and chronic bronchitis, the treatment or the cough in these patients will be treated with quitting the smoking. They have to quit the smoking. They have to avoid the
pollution, they have to quit the smoking, they have to avoid the pollution also. And in some cases, because the component of bronchitis is there, there occurs a lot of inflammation in their bronchus, so we have to give steroids for treating the cough in these individuals. And sometimes because of the bronchitis there occurs a lot of bronchospasms, their airway becomes very much narrowing and they are having difficulty in breathing, and that can contribute to cough also. For that we also require the bronchodilators, and sometimes the steam inhalation will also help in such cases, steam inhalation, and their cough that will then be much very much improved with such approaches. Some patients can have cough because of the abnormal airways, like a condition called as bronchiectasis. What happens in bronchiectasis, the large airways of the respiratory tract become very much dilated, and these dilated airways are predisposed to a lot of infection, and they collect a lot of sputum in them, and a lot of mucus get collected in these dilated airways, and this mucus and sputum irritate these respiratory passages, and patient can have lot of cough and sputum in bronchiectasis. Here we can see the CT images of the bronchiectasis changes. Here we can see the lot of dilated airways, and here the X-ray findings of dilated airways where the mucus get collected, and this collected mucus irritate the air passage again and again, and the patient can have cough. So the cough suppressants will not going to help such cases, as we know that a lot of sputum is collected, and on the top of that if we give the cough suppressants, the sputum remain collected there and the patient cannot cough, and this mucus collected mucus will get again and again infected, and the patient can have again and again cough. So for that cases of bronchitis we require the chest physiotherapy. Here we require the chest physiotherapy, and along with chest physiotherapy we require the postural drainage. So postural drainage and chest physiotherapy will help with the help of gravity these sputums get removed from their respiratory passages. Here we can see if you have the bronchiectasis or the changes occurring in the upper lobe of the lung. Here we can see on the anterior and upper lobe are affected, here the posterior and upper lobes are affected. So here a lot of sputum is there, so this sputum has to be removed. So what we can do, we can change the position of the patient. This is the postural drainage I am talking about. So we will keep the patient in the semi reclined position, and this will help to drain this mucus. Here the mucus from the upper lung will go down with the help of gravity into the main respiratory passages, and when it reaches the main respiratory passages, and as the patient cough, this will remove from the trachea. So in this way the gravity will assist in this case. Similarly here, if the posterior and the upper lobes are affected of the lung, the patient should be keep in leaning forward position. Here we are going to keep the patient in leaning forward position. And if the posterior and lower lobes are affected, the position of the patient should be prone with head towards the downside, and as a result of which this lot of sputum will go in this direction, and it will come in the main respiratory passages, and from here the sputum will move out, and the irritant sputum will not be there, and the patient get relieved of cough. And also if the patient having the lot of sputum collected or dilated bronchitis changes is seen in the here we can see in the right side of the lung, then you have to keep the position like this in the left side down, and from the right side the secretions will go down into the main respiratory passages. From here they are removed. Similarly, if the left sides are affected, the patient right side should be down, and from the left side the secretions will go into the main passages, and from here it is removed. And if the again if the this is the if the anterior and lower lobes are affected, you have to keep the position like this, the head towards the down, and the patient should be in supine position, and this will track the sputum in the main respiratory passages, as we can see, and it is removed from the main respiratory tract, and because of which the patient will get a lot of relieved. Here the cough suppressants will not work. Here the chest physiotherapy and the change of position of the patient will help in clearing the sputum from the respiratory passages. Some patient can have cough from a long period of time. As we know, when a cough for more than 2 weeks along with low grade fever, these are the symptoms of pulmonary tuberculosis, which is very common in India, and we know that this pulmonary tuberculosis can also cause cough. And for treating the pulmonary tuberculosis, the normal cough suppressants will not work. We have to treat their bacterial infection that is caused by Mycobacterium tuberculosis, and for that we know we have the drug therapy, as known as the anti-tubercular therapy, which is given for a period of 6 months. So anti-tubercular therapy, where it will work here, and we prescribe this anti-tubercular therapy or ATT for a period of 6 months, and then their cough will go. Some patients can have allergies in their nasal passages and in the sinuses, and these sinuses sometimes get infected, and there are allergic component in the nasal passage, and there are a lot of secretions which get trickle down from the sinuses and the nasal passages down the throat, and this is called as this is post nasal drip. This post-nasal drip can has also patients presents with cough symptoms, like they have constant desire of trickling the secretions down the throat, and that can irritate their respiratory passage, and the patient can have repeated cough again and again. So in such cases, since infection, we will give the antibiotics to treat their sinuses infection. In the sinuses, we give the antibiotics, and also because allergy component is there, there is lot of histamine produced, so we have to prescribe the antihistamines to these individuals. Also, since the nasal passages are a lot of congestion in the nasal passages, we prescribe them the nasal sprays that contains the decongestants. So we prescribe them nasal sprays that will decongest their nasal passages, and they will be relieved of cough because of the nasal decongestants. Sometimes they may require the corticosteroid also to treat the inflammation occurring in their sinuses and in their nasal passages. In some patients, the cough is due to acid reflux that can move from their gastrointestinal tract into the esophagus, and this acid will irritate the respiratory passages, and that can cause cough. And this condition is called as the gastroesophageal reflux disease, and this is because of the production of lot of acid in their stomach. And for cough due to gastroesophageal reflux disease is treated with proton pump inhibitors. Proton pump inhibitor will work better here, and the drugs like pentop we will give to treat their cough. And acid suppression can also be done by H2 blockers like your famotidine. And also you can increase their gastrointestinal motility. For treating their cough, we will give the drugs that will increase the motility of the gastrointestinal tract, and the drugs here that increase the motility include your mozapride and levosulfide. Besides these drugs, we also advise the diet modification in patients of gastroesophageal reflux disease. Diet modification, like patients should avoid eating tea, coffee in the evening, and they should avoid smoking, and that will help more in these patients. Also, we have to, while sleeping, their head end of the bed should be elevated. Head end of the bed should be elevated. That will also provide some relief in the cough in patients of gastroesophageal reflux disease. And one more condition we know that asthma is a hypersensitivity disorder of our tracheobronchial tree. It is a hypersensitivity of the respiratory tract, hypersensitivity of the tracheobronchial tree, and that can cause cough. And the patient with asthma usually have seasonal variations, and they can also have cough. Along with cough, their bronchi are very much constricted. Their bronchi are constricted, and because of which they have lot of wheeze and dyspnea, their difficulty breathing, and they are also having the allergy and inflammation. So for cough of patient with asthma, we require to treat their allergies, inflammations, and all the component of bronchospasm. For that, for bronchospasms, we have the drugs like we give the beta 2 agonist in the form of salbutamol. We will give the beta 2 agonist, and then for their inflammation, we have the drugs like corticosteroids. We will advise the corticosteroid to control their inflammation. For allergy, since there is a lot of histamine produced, we will give the antihistaminics to the patient like levocitrazine. Antihistaminics like levocitrazine. So in this way, the cough in patients of asthma will be treated. So there are certain drugs that can also cause cough when given for a long period of time. For example, your angiotensin convertase enzyme inhibitors. For example, the drug in this group is ramipril. These drugs can cause the cough.
So first we understand why these drugs are given. These drugs are angiotensin convertase enzymes. So we'll see the normal mechanisms. Normally, what does the angiotensin convertase enzyme do? It will convert your angiotensin 1 to angiotensin 2, and this angiotensin 2 then works on the blood vessel. So it will work on the blood vessels. So normally the blood vessels are dilated, and because when the angiotensin 2 will come, these blood vessels become constricted. These blood vessels become constricted, and that will increase the blood pressure. That will increase the blood pressure because of the presence of angiotensin 2. So when we give ramipril to the patient, it will inhibit this angiotensin convertase enzyme. So angiotensin 1 will not be converted to angiotensin 2, and the action of angiotensin 2 will not take place. That is, it will not constrict our blood vessels, and because the blood vessels are not constricted, and therefore the BP will not increase, and the blood pressure will fall down. This is normally we prescribe ramipril for reducing the blood pressure. So in addition to the conversion of angiotensin 1 to angiotensin 2, the angiotensin converting enzymes will also degrade one enzyme known as the bradykinin. It will also degrade the bradykinin. And we should be knowing that, and we also know that this bradykinin works on our respiratory passages. In the nerve endings of the respiratory passages, what does this bradykinin do? Bradykinin irritate these nerve endings of respiratory passages, and because of the irritation of these nerve endings, this will result in cough because of the presence of bradykinin. So as we give these enzyme inhibitors, these angiotensin converting enzyme inhibitors like ramipril, it will do, it will not be able to degrade this bradykinin, and as a result of which there is production of lot of bradykinin, and this lot of bradykinin then work on our nerve endings in the respiratory passages, and that will cause cough. So in this way, these drugs ramipril will cause cough. So if the cough is occurring because of these drugs, we have to stop these drugs, and we have to substitute these drugs with drugs like your angiotensin receptor blocker. These are the drugs that will work here. It will work directly on the receptors of the angiotensin 2. The drugs in this group, we have the drugs like telmisartan, losartan, telmisartan. These will help here. So if the cough is occurring because some patients are taking having blood pressure, and they are taking these drugs quite frequently, so we have to advise them that you should stop taking these drugs, angiotensin converting enzyme inhibitor, and we will switch them to drugs like angiotensin receptor blockers like telmisartan, losartan. So these drugs will work there. And sometimes the patient can have cough because of the viral infection. These types of cough are the post-viral cough. For post-viral cough, usually no treatment is required, no specific treatment is required, and this type of cough is subsides by itself. So there is no specific treatment for post-viral cough, no specific treatment, and they will subside of its own. So these are the approaches of how we are going to approach and treat. So we will continue our topic on drugs for cough. Today we are going to talk about our antitussive group of the drugs. So what are antitussives? We will now talk it about. So antitussives are those group of drugs that are used basically to control the cough. They are not going to eliminate our cough. They are just we are given for controlling the cough. They do not eliminate or do not treat the exact reason why the cough is occurring. They only control the cough. And these antitussives group of drug, they are basically we prescribe them for dry cough and the cough where the patient has non-productive nature of the cough and dry cough, and this is unduly irritating to the patient, and for that purpose we give these antitussives group of drug. So what these drugs do, these drugs basically act on the central nervous system in the cough center. In the central nervous system in the cough center, these groups of drug act. And besides the central nervous system, they also act in the periphery, in the respiratory tract. In the periphery, it also acts on the respiratory tract, these antitussives group of the drug. So we now see what is the mechanism, how the cough occurs, and how this group of drugs, the antitussives, act. So what happens when the patient is having the lot of chemicals or irritant or any mucus that is irritating the respiratory passages? So normally the what happens is that there are certain impulses that are being generated, and these impulses are generated from the respiratory passages, and these impulses goes to the cough center, which is located in the medulla. Here it is our cough center. This is the cough center, and it is located in the medulla oblongata. Here is our the cuff center. So what happens when there is a lot of irritation and smoke particle inhale or foreign particle goes to the respiratory tract, these impulses then goes to the center, that is the cuff center in the medulla oblongata. Here is the cuff center, and when these impulses stimulate this cuff center, so what happens, there is initiation of cuff reflux through various muscles that are being stimulated from these impulses. These muscles of the vocal cords are stimulated, and muscles of the larynx, pharynx, abdominal muscles, and all those muscles that work in a coordinated way to initiate the cough reflux. So this is the normally how does the cough happens. So what these antitussives group of drug do, they basically act at two levels. First, they act at the cough center level and also act at the periphery in the respiratory tract. So these impulses which are generated in the periphery, these are called the tussle impulses. These are called the tussle impulses. So these tussle impulses, or when we give these drugs, the antitussives group of drug, they basically inhibit these tussle impulses, and this leads to decrease, or the cuff center is unable to get stimulated because of the inhibition of these impulses. So there is no more impulses reaching the cuff center, and that's why the cuff is not initiated, and the cuff is getting controlled with the use of these antitussive group of drug. So here it is inhibiting the tussle impulses, and also these drugs also increases the threshold of the cuff center for cuff. So they increase the threshold of cuff center. So they increase the threshold of cuff center. So normally there are receptors which are present here in the cuff center. These receptors senses the stimuli, irritant stimuli, and because of the raised threshold of this they require a lot of irritant molecules now to stimulate the center. Initially it may be with normal spaced, with two molecules suppose if stimulate this cuff center. Now because we have given the antitussives, we require say 10 molecules now to stimulate this cuff center. So they increase the threshold, of cuff center. So normally with 2 molecules of irritant, suppose the cuff center is getting stimulated. Now with 10 molecules, at least 10 molecules are required to stimulate this cuff center. So in this way, these antitussive groups of drug act at two levels. First at the cuff center level, where they increase the threshold of the cuff center, and at the periphery in the respiratory tract, they inhibit the tussle impulses. Now we'll see the classification of antitussive group of drugs. The classification of antitussives are classified as opioids, non-opioids. Besides opioid and non-opioids, we have the antihistamines and peripherally acting antitussives drugs. In the opioid group of drugs, we have the drugs like codeine, which is a standardized antitussive, which is also the methyl morphine, and then we have the ethyl morphine and codeine. Then among the non-opioids, we have the noscapine, dextromethorphan, clofenidianol. These are the non-opioids. Among the antihistaminics, the antitussive group among the antihistaminics include the chlorpheniramine, diphenhydramine, promethazine. And in the peripheral acting antitussive group of drug, we have the prenoxdiazine. So these are the classification of antitussives. We have the opioids, non-opioids, antihistaminics, and peripherally acting antitussives. So first talk about the opioid groups of drug. So as we know, these are the opioids, antitussives. They act on the mu receptors, which are present on the cuff center in the medulla oblongata. They act on the mu receptors of the brain. In the central nervous system, in the cuff center, we have the mu receptors. These opioid groups of drugs act on the mu receptors present on the brain in the central nervous system. And as we know, mu receptors is being blocked by another drug known as the naloxone. So naloxone is the antagonist for these group of drugs. Naloxone is the antagonist. They block the mu receptors. On the central nervous system. So among the opioids, the standard drug is the codeine. It is the standard antitussive. It is the standard antitussive. And its duration of action is 6 hours. And as we know, it suppresses the curve by acting on the central nervous system. And this codeine has a drawback it causes constipation as its major drawback. Besides constipation, it has addiction liability. It causes addiction, and it also causes sedation. Since it causes sedation, it is to be used very cautiously in patients who are drivers.
So patient should not drive while taking codeine tablets. So it causes constipation, addiction, sedation, and at larger doses it can cause respiratory depression also. So that's why it is contraindicated in patients who are having poor respiratory drive. They are contraindicated, and also it is contraindicated in asthmatics. It is contraindicated in asthmatics. So codeine comes in the form of syrup as well as tablet. As we can see, it is 30 mg. That tablet, the doses of codeine is 15 to 30 mg tablets comes. And also there is a syrup which comes in the form of linctus as codeine phosphate. Here we can see codeine phosphate linctus. So its 5 ml contains about 15 mg of codeine in it. 15 mg. So codeine, as we know, it is a standard antitussive. It is having the half-life of its action is of 6 hours. And this drug is also should be avoided in children. It should be avoided in children. So this was about the codeine. Now another drug is your ethyl morphine. Codeine was methyl morphine. Another drug is ethyl morphine. About this drug is closely related to the codeine, and its action and efficacy is almost similar to your codeine, and but it is less constipating. It is less constipating drug when compared with codeine. It is less constipating, and its dose is 10 to 30 mg given thrice daily, TDS dose. This is the dose of ethyl morphine. And it also comes in the tablet form, as its name is deonindon, and it is comes as 16 mg tablet, deonindon. This is ethyl morphine. Now we'll talk another drug is your fall codeine. We have the fall codeine. Fall codeine, this drug has no analgesic properties, no analgesic, and it also has no addiction property, no addiction and non-analgesic. So this is for fall codeine, non-analgesic, no addiction liability. But its efficacy is as antitussive is similar to codeine. Efficacy is similar, but the important thing about fall codeine that it is a longer acting drug. It acts for 12 hours when compared with codeine, which acts for 6 hours. It acts for 12 hours, and the dose of fall codeine is 10 to 15 mg. So this was about fall. So we are discussing the antitussives group of drugs that are used for dry cough. We have already discussed the opioid group of drugs, in which we have discussed the standardized codeine drug, and we have also discussed the fall codeine and ethyl morphine. These are the opioids antitussives. So other antitussives are, we have the non-opioids, then we have the antihistamines, and the drugs that act peripherally acting antitussives. Among the non-opioids, we have the drugs like noscapine, and then we have the drugs like dextromethorphan, and then we have one more drug is clofidinol. So these are the non-opioids group of drugs: noscapine, dextromethorphan, and clofidinol. So today we will be focusing on the non-opioid group of the antitussives. So let's talk about the non-opioids. First we will talk about the noscapine. So this noscapine is a opium alkaloid. It is an opium alkaloid, and this drug belongs to the benzo isoquinoline series. This noscapine belongs to benzoisoquinoline series, and it is an opium alkaloid. So what is the mechanism of action? That it acts on the central nervous system in the cough center, and as we know, most of the antitussives block the cough center present in the medulla oblongata. So noscapine blocks this cough center present in the medulla oblongata. Here, as we know, that most of the opioid groups of the antitussives, they have strong affinity with the mu receptors, as we know, but this noscapine has very weak affinity for this mu receptors. It binds very weakly. It binds weakly bind with the mu receptors which are present on the brain. So as a result of which, as we know, most of the opioids reduces the pain because of the strong affinity with the mu receptors. But this noscapine, since it binds very weakly with these mu receptors present in the central nervous system, so it does not reduce pain, and also it does not have any addiction forming properties. So it does not cause any addiction, and it does not reduces the pain also. However, the side effects like headache and nausea do occur with the use of noscapine. Headache and nausea do occur with noscapine. It is most of the time prescribed to treat whenever there occurs the spasmodic cough. Spasmodic cough, when, for example, when the patient has, for example, asthmatic patients, when they have recurrent attacks of spasms, then this noscapine is very good drug for that. It is used for spasmodic cough. And it also has the properties where it causes the relaxation of the respiratory muscle, so it has a soothing effect on the muscle also, so it has a muscle relaxant property also. Muscle relaxation also. One more property with the noscapine is that noscapine reduces the cancer cell growth. So this property is under research, and it is now being researched for anti-cancer therapy, this noscapine. About the doses of noscapine, the noscapine is given at a dose of 15 to 30 mg. 15 to 30 mg. And it is comes, as we know, it comes in the form of syrup, as well as we have the tablets of noscapine. Here we can see the noscapine tablet of 25 mg, and also it comes in the form of syrup. For each 5 ml of the syrup of noscapine, it contains about 7 mg of noscapine, 7 mg. So this was about the noscapine, which is a non-opioid antitussive group of drug. So we are discussing the non-opioids. We have already discussed the non-opioids. In the non-opioids, we have discussed the noscapine, and now we will discuss the dextromethorphan, which is an antitussive. As we know, antitussives acts on the brain in the central nervous system, and as we know, in the central nervous system, in the medulla oblongata, we have the cuff center. And this dextromethorphan drug blocks the cuff center, and thus the initiation of cough reflex is not initiated, and the patient gets relief from the cough. And especially for dry cough, it is given this drug, this dextromethorphan. So besides the direct blockages of the cuff center in the medulla oblongata, there are certain receptors which are also being blocked by these dextromethorphan, and these receptors are scattered throughout the central nervous system, and these are the receptors are called as the NMDA receptors. NMDA receptors. So dextromethorphan also blocks these receptors present in the central nervous system. So normally, what is the mechanism? How does the NMDA receptor works? So let's understand. Suppose this is the neuron, this is the neuron, and in the neuron we have these receptors. These are the various receptors for present on these neurons. These are the receptors called the NMDA receptors. NMDA receptors, and normally these receptors binds with glutamate. These receptors bind with, this is the glutamate molecule, glutamate. So whenever the glutamate binds with the NMDA receptors of the neuron, so what happens? There is the opening of the calcium channels. The calcium channels gets open and it enters the neurons. So there occurs a lot of calcium accumulation in the neuron. As a result, whenever the calcium gets accumulated inside the neurons, so there starts the excitatory impulse. So as a result of which, the impulse starts spreading throughout the neuron, and these impulses then sent to the various systems of the respiratory tract for starting the cough reflex. So here the impulses reaches the respiratory tract for starting the cough reflex. So this is how the NMDA works. So this drug, whenever given, they block these receptors, these NMDA receptors, and because of which this excitation of these neurons does not take place, and as a result the impulses reaching for the cough is not reached, and as a result of which patient get relieved from the cough. But however, because of the high dosages, at high dose of these dextromethorphan, these NMDA blockages can lead to the decreased excitation of the central nervous system, and as a result of which the patient can have certain dissociative effects. As we know, dissociative effects are noted with this drug dextromethorphan, like a patient get detached from the environment, and had high doses of dextromethorphan, the patient can detach from the environment and also can have hallucinations. And this property is being used by many drug abusers with this drug of dextromethorphan. So the patient can have abuse this dextromethorphan because of its dissociative effects at high dosages because of the blockages of NMDA receptors with dextromethorphan. Besides these effects, dextromethorphan also causes certain side effects, like it can cause your drowsiness, dizziness, and even at high doses it can cause ataxia. These are the side effects I'm talking about with dextromethorphan. Patient can have ataxia, patient can have drowsiness, and patient can have also hallucinations with dextromethorphan. And about these dosages, the dose of dextromethorphan is 10 to 20 mg, and it comes as a syrup for as well as in the form of tablet. Here we can see 20 mg dextromethorphan tablet, and here we can see the 100 ml syrup of dextromethorphan. This dextromethorphan is also used in various cough formulations as a agent. It is used in various cough formulations. So it is comes as syrup form as well as the tablet form, and it is usually prescribed for dry cough. This is dextromethorphan. Now another drug is your non-opioid is clofidinol. So about this drug is centrally acting. As we know, it is an antitussive. It acts centrally acting drug, and it has slow onset as well as long duration of action. So its important properties: it has slow onset and long duration of action with clofidinol. Long duration of action. And about the side effects with clofidinol, patient can have dry mouth with clofidinol, dry mouth. Patient can have vertigo and irritability with the use of clofidinol. And the dose of clofidinol is 20 to 40 mg. 20 to 40 mg. It is also comes in the form of Linctus, and the 5 ml of Linctus contains about 20 mg of your clofidinol. So this was about the non-opioids antitussives.
So we are discussing the antitussives. We have already discussed the opioid antitussives, non-opioid antitussives. Today we will discuss the antihistaminics. So antihistamines also given for the cough, and it is usually given whenever there is allergy or whenever there is running nose, sinusitis is there associated with the symptoms of upper respiratory tract. There we can prescribe the antihistaminics. So this how this drug works. First, let's understand how the cough occurs. Whenever there is, for example, this is the dust particle or say any allergen. Suppose this is the allergen, which is not required by the body. Suppose this allergen try to enter our respiratory passages. As this allergen tries to go inside the respiratory passages, so what happens? Our defense mechanism activated. Suppose this is the bronchus I am drying, and this is the bronchus, and these are our two lungs. What happens whenever this allergen or any dust particle or any foreign materials try to enters the our respiratory passages? So our respiratory passage does not want this foreign material to enter. So there are certain defense which is gets activated, and this defense activation occurs because there is release of histamines, and this causes the bronchus to undergo bronchial constriction. So first happens what the bronchus undergo small narrow in size to limit the entry. It will limit the entry of this foreign material or allergen inside our respiratory passages, and this is the defense mechanism by bronchoconstriction. And also when it will enter, there is also in the respiratory passages we have these cells I am drawing here. These are the goblet cells that produce lot of mucus. It produces mucus, and here lot of mucus is being produced, and I am showing here this is mucus. This is the mucus, and we know that mucus is very much sticky, and it will bind with these allergen or any dust particle or any foreign particle being binded by being attached by the mucus, and it will not allow this dust particle to go further down the respiratory passages to reach the lungs. So this dust particle is also being limited by this production of mucus, and it is also the defense mechanism. So first defense was the bronchoconstriction, then there is production of mucus to limit the entry of this allergen or any dust particle inside our lungs. And as we know, there is bronchoconstriction and there is mucus production. So what happens? Suppose I'm drawing here, this is the bronchus and it undergoing bronchial constriction, and there is a lot of secretion get collected. So this will lead to the activation of the receptors which are present in the respiratory passage. These are called the stretch receptors. Stretch receptors, they are activated by the secretions, by the bronchospasm, bronchoconstriction, and mucus will activate these stretch receptors. They will activate it, and what these stretch receptors do, these stretch receptors then send the signal to our central nervous system. Here is the central nervous system. Here is the cough center located in the medulla oblongata. Here is the cough center. cuff center. So what happens, this signals goes to the brain in the central nervous system, in the medulla oblongata, the cuff center get activated, and it then produces certain excitatory impulses that goes down into the vocal cord, larynx, pharynx, abdominal muscle, and even diaphragm. And these muscles of this vocal cord, larynx, pharynx, they get activated and work in a coordinated way to initiate the cough reflux. Cough reflux initiated and the patient tried to cough. It also the defense mechanism, and as the patient cough, this dust particle which was and trying to enter, it will be thrown out. It will be thrown out. So this was again the defense mechanism which occurs to limit the entry of allergen or foreign particle outside the body. So this was how this body tries to prevent the entry. So now I will tell the at a very molecular level how this is happening, how the bronchoconstriction occurring at a molecular level. Suppose this is the bronchus, and in the bronchus we have these smooth muscles, respiratory smooth muscles. These are the respiratory smooth muscles. And also in the bronchus, I will draw here certain glands, or these are the goblet cells are there. These produce the mucus. So I will zoom this out later. There are certain receptors also. There are receptors on the goblet cell and on the respiratory smooth muscle. This is the respiratory smooth muscle, and these are the goblet cell which produce the mucus. So what happens, these are the receptors I am drawing here, the histamine. These receptors are for histamines. These are H1 histamine receptors, and some are muscarinic also, muscarinic M3 receptors. So they are present on the respiratory smooth muscle and goblet cells. So what happens, I will zoom it out. Suppose this was the cell here, this is the respiratory smooth muscle cell, here the H1, this is the H1 receptor, the histamine. Now suppose this is the histamine molecule. Whenever the allergen enters the respiratory passages, what happens, there is production of lot of histamines. So what this histamine will do, histamine try to bind with the receptors present on the respiratory smooth muscles, and as a result there occurs the activation of this respiratory smooth muscle. There undergoes the signal transduction. Here I am not going to detail here what type of signal transduction is taking place. So you just remember, whenever the histamine bind with the histamine receptors, there occurs the opening of the calcium channels. As a result, lot of calcium enters the respiratory smooth muscle, and these respiratory smooth muscles get activated, and it undergo depolarization, and they start contracting. They become smaller in size, and as a result of which, whenever the smooth muscle contract, the bronchus becomes smaller, and this is how the bronchoconstriction take place, as a result of binding of histamine with the histamine receptors on the bronchial smooth muscle. Also, suppose this was the goblet cell, this is the large goblet cell, there is the histamine also bind with these receptors of the goblet cell, and the goblet cell produce lot of mucus as a result of activation by the histamine. This is histamine binding with the histamine receptor. So this mucus is also being produced as a result of binding of acetylcholine with the M3 receptor. So when we give antihistamines to the patient, antihistamines, what it will do, antihistamines will block the binding of histamine with the histamine receptors here and here also. So what happens, the bronchoconstriction will not take place, and also the mucus production will decrease. I would like to tell here that certain antihistamines also block the M3 receptors, so further mucus production will go down. So bronchoconstriction will not take place and mucus production will reduce, and as a result, as we know, whenever there is no more irritation or no more bronchospasm, no more secretions are there, so there is no more impulses that are being generated, and these impulses will not reach to the central nervous system to cause the cough. So the patient will be relieved from cough. Also, histamines also work in our central nervous system. So histamine has the receptors on the central nervous system. So whenever the histamine enters the central nervous system, so there are receptors which are scattered throughout the central nervous system for histamines. These are called the H1 type of receptors, most predominantly present in the central nervous system. And also the acetylcholine receptors are also present in the central nervous system, which are the muscarinic M3 type of receptors. These are the muscarinic receptors for the acetylcholine, muscarinic receptors. And also certain other receptors for serotonin receptors are also there, which are the serotonergic receptors. Serotonergic receptor, they are also present in the central nervous system. So whenever the histamines, especially the histamines which enter the central nervous systems, what it does, it activates the central nervous system by producing the excitatory impulses are being generated by the activation of the histaminic receptors and the muscarinic receptors and the serotonergic receptors. They send the excitatory impulses throughout the central nervous system, and this mechanism will keep the patient awake, and this awakeness is because of the activation of these receptors by the
histamines and the muscarinic receptors and the serotonergic receptors. So what does the antihistamines do? Antihistamines, especially the antihistamines, are those which are the first generation. So first generation antihistamines, especially the drugs like chlorpheniramine, promethazine, these are the first generation antihistamines, promethazine and even diphenhydramine. These are fat soluble and they easily cross the blood brain barrier and enter the central nervous system and block these histaminic receptors. In addition to blockage of these histaminic receptors, they also block the muscarinic receptor and serotonergic receptors, as a result of which these excitatory impulses which are generated, they are no more generated and the patient will remain no more awake and the patient becomes sedated. So these antihistaminics, especially the first generation antihistaminics, produce sedation, and this sedation also calms the patient from undue sensations of cough, and in this way they also relieve the patient from cough stimulus. And you should be remembering here, since they also block the muscarinic receptors, these antihistaminics produces the side effect like they produce the dryness of almost most secretions of the body, and patient can have dry mouth because of blockages of the muscarinic receptors on various tissues of the body. And now these are the drugs for the dose. These are the first generation antihistaminics which are used to given for cough. Here I can see the chlorpheniramine tablet. The usual dose of chlorpheniramine is 2 to 5 mg. Here I can see it comes in the form of tablet as well as comes in the form of syrup. And these are the chlorpheniramine tablets which are prescribed for, as we can see, it will relieve the patient from sneezing, running nose, itchy and watery eyes since they dry up the secretions, and they are also given for itchy throat. Here is the 4 mg chlorpheniramine malate tablets. And it also used as a combination with dextromethorphan. Here I can see each 5 ml of the syrup contains 10 mg of dextromethorphan and 2 mg of chlorpheniramine. So it has a slightly 2 to 5 mg of dose of chlorpheniramine. You have to remember it. Then one more drug is also the first generation antihistamine is the promethazine, also known as the Phenargan. Here we can see the syrup of Phenargan, where 5 ml of Phenargan contains 5 mg of promethazine. And also one more drug is the diphenhydramine. Here we can see the diphenhydramine 25 mg capsules are there. They relieve the patient from coughing, sneezing, running nose and sore throat. So this was about the antihistamines which acts to relieve the cough.